We know that about 2 out of every 5 physicians is expected to age out over 65 over the course of the next decade. We know that about 1 in 4 physicians during the pandemic thought about early retirement. 1 in 5 has said they'll likely leave their practice within the next 2 years. And 1 in 3 have said they'd like to reduce their workload over the course of the next year. We know as surgeons, there's not an easy off-road to reduce your workload. Part-time surgery programs don't tend to exist much out there. Specific to surgeons, we know that, again, almost a 30,000 shortfall in surgeons over the course of the next decade. And this is in the backdrop of surging demand for surgical procedures and surgical skill sets. So this has led to the development of the Surgicalist model. And there's sort of 2 audiences that this appeals to. There's your classic hospital model, where the hospitals and healthcare centers don't necessarily like to pay for call, particularly if it's driving out migration of services. Patients are seen in the hospital, but they're getting their ultimate care delivered elsewhere. At the same time, they have an obligation to provide 24/7, 365 coverage for their community at large. And on the other side, you have the providers, we the surgeons. We don't like some of the inefficiencies that go with call. We've been driven to be more productive, see a greater volume of patients in the clinic, drive a higher surgical volume, and that creates conflict or stress, what we call the stress of care conflict. It's very difficult if you have 40 patients sitting in your clinic to then move laterally and care for someone in the ER. But at the same time, surgeons certainly care about that person in the ER. So it's hard to be in 2 places at once, and that works both if you're in the OR or in the clinic. And so that's led to the development of the Surgicalist model. And so what is this model? Well, typically we will partner with a healthcare facility or network or even a private practice orthopedic group and sort out what are their goals, what are their needs, and we'll work with each one of them to develop a collaborative partnership where we can both recruit and deploy what they need in terms of surgeons, APPs, et cetera, and fulfill their needs, whether that's ER coverage, call coverage, trauma care, elective care. And so that covers what the hospital needs. On the other side, like I said, is the providers. So for a surgicalist, it differs than the typical locums model. You're not just plugging and filling a gap. You're dedicated to the hospital that you're committed to. And you're there on a consistent basis, typically 7 to 10 days per month. You don't need to live in that community. You can commute to it, but it's consistent. You're there month after month. So you do get to know the ER staff, the OR staff, the workflows, the processes at that facility, as well as the referring doctors and even the ER doctors. But when you're away, the other 20 days of the month, there's some significant benefit. At this point, you don't have any care responsibilities. There's no pager, there's no phone calls, there's no inbox in the EMR. You get to be free. And that's because what you've done when Synergy deploys a team is you're passing the baton to your Synergy partner. They are now on, they're going to take over the responsibility of that care. And it's part of our job to vet and make sure we have quality surgeons that are doing that. So it's much more of a team-based approach to our patients. So it's really, in many places where it's been used, has solved the on-call dilemma in providing access to care. So, for example, in a community model, we will partner with the community surgeons. If they happen to need on-call coverage, we provide the on-call coverage. That frees them up during the day to optimize their elective practices. It restores their quality of life because now they're doing those busy clinics and OR elective schedules without having to worry about the ER stuff. And on the flip side, for the surgicalist, they're able to go and do the orthopedic surgery, practice the craft they love without the administrative burdens of, say, a private practice management or an employed model. The model's been successful. It's currently deployed in 140 hospitals nationwide. It's expanded. We started with orthopedics, but now do general surgery, both elective as well as trauma surgery, anesthesia services, and emergency medicine. So who are these surgicalists? Well, first and foremost, they're highly skilled orthopedic surgeons. The average age of our surgeon is in the mid-50s. They can function independently. They have a varied skill set. Some are trauma trained, some are trauma fellowship trained, some are just generalists, some are sports docs. But they're looking or at a point in their career where they want to reduce those administrative hassles. Or again, they don't want to be in an employed position. They still get to do orthopedic surgery. In fact, they get to focus on it. They get a predictable schedule, but it's also very flexible. Like I said, you're 20 days a month, you are off. And again, it gives you the option and your family the option to live anywhere, but still provide care in a local community. And lastly, they're team players, again, because this is more of a team model. Whereas historically, we've taken care of a patient through all aspects of it. Here you are passing the baton, and your partners are caring for patients when you're away. So again, Rand is one of the co-founders of the company, and again, one of their philosophies was putting the joy back into medicine. I'm going to put him a little on the spot here and ask him a couple questions, and he can give us some of the background and history of the Surgicalist program. So first off, Rand, can you give us an example of where the Surgicalist model has benefited an orthopedic surgeon?
I think the biggest impact we've made is we've extended a lot of surgical careers. As you all know, guys are passionate about operating, passionate about taking care of patients, and yet not so passionate about dealing with the administrative hassles, maybe looking at your life and saying, what have I missed out over the last part of my career? This gives you a chance to extend your career, where you can work 10 days, 7 days a month. You don't have to relocate, you don't have to uproot your family. We provide a team so that when you're off, you're truly off. You trust your partners to take care of your patients. And I think the biggest impact we've had is we've extended a lot of surgical careers.
Yeah, and certainly, like I mentioned earlier, there's not often an easy off-ramp in orthopedics. And so this does allow you to go to a part-time model but still practice your craft. Lastly, any advice for surgeons that are at a transition point in their career?
I think this is truly a unique model. It's different than locums. What makes it different? Several things. You're going to the same facility. You're not trying to figure out where the bathroom and the OR and the coffee pot is. You know where it is. You're part of a team. You trust your team. You don't have to relocate. It's difficult to be a part-time surgeon if you're employed by a hospital. If you're part of a group, no one's going to let you off the hook with your fixed and variable overhead. So this is a very unique model in that regard, and it truly can extend careers.
Yeah, we have certainly seen that. Like Rand mentioned, average age of our surgeons is roughly in the mid-50s, and it does tend to be something that, again, the surgeons are comfortable practicing. They want to continue to do it. They just don't want to do it at the same pace they've done it for the last 25 years.
Okay.
So I'll talk to a couple of other things. So access to care. I was just going to give you one example of a typical model for us. This was a 2-hospital system that came to us. They had some contracted physicians as well as private groups in town covering their call. But they had two problems and 2 goals they wanted to achieve. They wanted to both increase their orthopedic surgery volumes in the hospital, but also prevent the transfer of orthopedic cases out. And so they partnered with Synergy. This is a trauma program. We came up with a model where we sent 3 surgeons there on 10-day rotations, just 1 surgeon per day, covering just the on-call aspects of it. But that provides them with 24-hour coverage at two campuses. Very successful first year. Second year, they doubled it. They went to 2 surgeons per day due to the increasing volume, added APPs, and also added a 3rd hospital to the system. And it's continued to mature. In year 6, the program obtained level 2 trauma designation. And now we're in year 8 with this program. It's grown to 8 full-time surgeons, 4 PRN surgicalists, and 2 APPs to support the practice. The Volume has grown significantly. Orthopedic volume, again, that was one of their goals, is up 40% since 2019. They've been able to grow the healthcare system from 2 sites to 3. And lastly, they obtained that level 2 trauma designation. So what Synergy is able to do is go into these facilities and create a predictable staffing model, drive increased volume, grow programs, and this is true on both the trauma side as well as the elective practice side. So a couple takeaways we want for you here. And speaking to the Surgicalist first, it gets you predictable real-time off. That's something that I didn't experience through most of my career, and many of you haven't as well. It gives you peace of mind. You know that you're part of a team that's deployed, and so your patients are being cared for even when you're not there to provide that care directly. It absolutely restores work-life balance and gives you time to pursue personal pursuits. We have people that are out climbing mountains. We've got docs that are training for triathlons, and these are all pursuits they can do because now they've got the time to do it. It also really empowers surgeons. Instead of it being a grind, they're focused on it those 10 days. They enjoy being there because they get to do it at a pace and speed at which they like. If you guys have questions, I'm instructed to tell you to use the aisle mic so that we can hear you and everyone else can hear you.
Okay, I'm Rafael Fernandez. I just want to make a comment. I only have good things to say about these people because it's not just that you get to do what you want to do when you want to do it, but in this model, different than a regular locum tenens, you develop good relationships with the other surgeons that are actually part of your team. So I think that first of all, I want to thank them. And second, I want to let you know that this is a tremendous model, and I choose it anytime over any other locums.
Thanks, Raphael. Nice testimonial for you. That wasn't even planned. Anything else we can answer for people?
Questions. Are you on 24/7 for that 10 days?
What's
your pay model?
Yeah, it really depends on the particular facility model. So at some places it's 12 hours on, at some places it is 24 hours on, but you're not running necessarily a clinic concurrently. You're really just dedicated to the ER. The payment model is one of an independent contractor, so it is not a W-2. You're not an employee. The pay varies per facility. There's regional differences in pay across the country, so it fluctuates a little bit in terms of that.
Are we talking salary or RVU or income? What exactly?
Yeah, so really it's a per diem. It's a per day amount.
One other point, you asked, are you on 24 hours? We're not putting you at level 1 centers where you're not safe to be there for a week or 10 days. Our job is to put a team in place where the volumes meet the demand so you can do it safely for a week to 10 days and not, and still get some rest at night.
I will preface my question. I'm not a surgeon or a clinician. I'm a healthcare advisor and strategy advisor for orthopedic programs. But can you talk more about how you integrate current staffing in orthopedic departments at hospitals or health systems? If they have PAs that they're using, what's your preference for either adopting their current care model versus implementing one of your own?
Yeah, honestly, we can do it either way. So, for example, in our community model, we'll be in that community's office and seeing patients there. And so in that type of model, we would take on the workflows and processes that are already in place by that group. But there are other times where we are working with the facility to set up a unique program for that. And that can include office design, office layout. We talked to them about implants, the full spectrum of orthopedic care. APPs, we do employ some, again, depending on what the model needs. Other times the facility has their own and they're work part of the team. I particularly like when it's someone that's on site, it's part of their team, because then they add another layer of continuity to the care of the patients.
I think one of the questions that might be out here for us physicians would be terms of commitment. Obviously, you wouldn't want somebody to come for 3 months and then leave. You've kind of not been a good investment on your part. So, terms of contracts, commitment.
Yeah, fantastic question. We usually ask for a 1-year minimum commitment. So you can certainly renew beyond that, and I think most docs do, but we do ask for at least a 1-year commitment. All right, well, thanks everybody for being here.